Thank you so much for the introduction, and thank you so much for having me in this meeting. I've been listening all day, and it has been extremely interesting topics that have been presented. So I will start by my conflict of interest. I am on a steering committee by a company called Vertex Pharmaceutical. So I think I'm not going to belabor the issue here. I know multiple speakers before me mentioned the toll of sickle cell disease throughout the world. And as you know, there is sickle cell disease very much everywhere in the world, but it is highly concentrated in Africa, where the majority of the patients live. There are around 1,000 patients that live in the United States that are affected with sickle cell disease. So as also many of you know, and this is again very redundant, but I'm going to go through it relatively quickly. Sickle cell disease is can cause significant morbidity and mortality in patients, and it can affect literally every organ. So it can affect the brain by causing strokes. It can affect the lung by causing acute chest syndrome. It can cause cardiac dysfunction by the fact that the patients will have pulmonary hypertension. It can cause avascular necrosis, as well as renal disease, which is all of them can lead to patients having shortened lifespan. So it is a multi-system organ dysfunction. And I tell my patients when I see them in clinic that sickle cell disease continuously hammers your body. You are continuously having side effects from sickle cell disease, even if you are not having any crisis. So it's like a hammer hitting at the wall 24 hours, 7 days a week. So a recent study done by Michael DeBon and the Hopkins group by Vanderbilt and Hopkins, and this is a study that looked at all adult patients between 2003 and 2016, and they looked at the overall survival for patients in that era. And despite the use of hydroxyurea, the median survival for adults was only 48 years. And the graph here lists the cause of death in all the patients. And as you can see, it is a variety of things, including acute pulmonary disease, infection, cardiac, and renal dysfunction. In the United States alone, we spend around $1 billion a year annually caring for patients with sickle cell disease. So it has a very high impact, not only on the patients, but also society. So what are the curative options? I know multiple people have talked today about curative options for sickle cell disease, and allogeneic transplant remain the only curative option, as Salim mentioned earlier. And clearly the best data is with the HLA identical siblings, specifically for those patients who are less than 18 years of age. They seem to do better than older patients in their adulthood. Unfortunately, at least this is US data. I know this might be different in various areas in the world. Around only 15 to 20% of patients here in the US have an HLA identical donor. And we have done, there has been a trial in the United States, a clinical trial network data that looked at unrelated donor transplants led by Shalini Shenoy. And unfortunately, this therapy was associated with very high risk of acute as well as extensive chronic graft versus host disease. So this trial was totally abandoned because of the high risk of GVHD. Haplostem cell transplant, haploidentical transplant is another option for patients with sickle cell disease. And now with the onset of the post-transplant cyclophosphamide, it's becoming easier to perform haploidentical transplants. And I know there are other trials using more graft manipulation that Salim talked about, the alpha beta T cell depletion, and trying to maximize the use of haploidentical transplant for patients. But you know, ideally, you like to have every patient to have a good option that minimizes the risk of graft versus host disease, minimizes the risk of graft failure. And I think gene therapy is a very appealing technology. And I know John Disdale presented some data earlier in this meeting on gene addition therapy for patients with sickle cell disease. So switching gears to transfusion-dependent beta thalassemia, again, this is mainly redundant information for the majority of the attendees. but there are 40,000 affected infants are born each year, and half of them are classified as transfusion dependent. Beta thalassemia, unlike sickle cell disease, is caused by multiple mutations, either related to deletions, insertions, but it is a very a heterogeneous group of genetic abnormalities that result in patients having transfusion-dependent beta thalassemia. Today, there are more than close now over 400 mutations that have been described. So beta plus denotes mild mutation that cause relative reduction on the beta globin synthesis, and beta zero means severe mutation that lead to complete absence of beta globin. So most patients with beta zero disease have a very severe phenotype. So patients with transfusion-dependent thalassemia require transfusions every 2 to 5 weeks, and this lifelong transfusion is required that results in multiple complications, which we'll talk about here in a minute. So again, as a reminder, patients with a genotype of beta zero, those patients do not make any normal adult hemoglobin. And most of these patients start transfusions in the first year of life, in fact, in the first 6 months of life, while patients who have beta zero, beta plus, or beta zero, beta E have milder disease. They make around 4, sometimes 5 grams of hemoglobin, allowing them to start transfusions a little bit later in life, but nonetheless, they are still transfusion dependent. So what happens as far as clinical manifestation is the biggest problem with transfusion therapy is iron overload to the liver, heart, endocrine organs. It can increase the risk of thrombosis, specifically in patients who are splenectomized. Now, there are many patients with beta thalassemia that come to our institution for transplant, have had splenectomies in the past, which potentially can increase the risk for thrombosis. They can have bone and joint manifestations, as well as cardiopulmonary complications. And a lot of the patients have growth failure, have endocrine abnormalities. So it can basically be a multi-system disease. So how do we treat beta thalassemia? As many speakers mentioned earlier, you give extended red blood cell transfusion typing with extended antigen typing in the red blood cells to minimize alloimmunization. Blood banks in most institutions that deal with patients with beta thalassemia perform extended antigen typing, and they are able to give the most compatible blood to patients to minimize the formation of antibodies. You monitor iron overload using liver and cardiac MRIs. One long time ago, when I was in medical school, and then as a resident, we used to do serial liver biopsies, which now we are not doing. And you can use iron chelation therapy, which now is much easier because there are multiple oral chelating agents that are available. Again, in the old days, it used to be only desferal, which is given subcutaneously. Most recently, luspatercept has been approved in the US and Europe, and it blocks the SMAD2/3 signaling and enhance erythroid maturation. And in the study published in New England Journal of Medicine, they showed a decreased frequency of transfusions in patients with beta plus and beta zero, but not in the beta zero genotype. So it did not benefit the patients with the more severe genotype. And again, as many speakers have mentioned, allogeneic transplant from HLA identical sibling remains the standard curative approach for patients with beta thalassemia. So why gene editing? So I'm going to concentrate today by talking about gene editing. Why gene editing in patients with beta thalassemia and sickle cell disease? Now, the story of gene editing started around 10 years ago with the discovery that there's a system called CRISPR-Cas9, which is able to perform very precise edits in the DNA. CRISPR-Cas9 was first described actually in the 1980s, but they did not understand why the repeated sequences in bacteria was present. And until recently, around 10 years ago, when Jennifer Doudna and Emmanuel Charpentier reported their paper exactly 10 years ago, showing that system can be used to precisely make changes in the DNA. It really opened the door to potentially using this technology to treat diseases, not only sickle cell disease and thalassemia, but actually many diseases these days are being targeted using this technology. So unlike gene addition therapy, where you need to use an antiviral vector, this is a viral-free technique where you can actually make the edits without introducing an antiviral vector. So these tools allow genetic material to be disrupted or deleted, corrected, or inserted at precise locations in the genome. So there are multiple ongoing clinical trials. If you go to clinicaltrial.gov and look at the number of clinical trials available these days for many diseases, including sickle cell disease, you will find multiple clinical trials ongoing or in preparation using CRISPR-Cas9 to treat patients with sickle cell disease and beta thalassemia. There are two approaches here. One approach is a gene disruption to induce fetal hemoglobin production, which is what we are going to talk about today. And there is more recent clinical trials opening, and I know they are accruing, but we haven't seen any data yet, using gene correction. So with sickle cell disease, because it's a single point mutation, it is very tempting to actually do clinical trials using gene correction to change the genotype to hemoglobin A, not hemoglobin S. And there are two ongoing clinical trials using this approach. What I'm going to concentrate on today, which is the most advanced trial that I have been one of the investigators in and have been involved in for several years, is using gene disruption to induce fetal hemoglobin. So why fetal hemoglobin? Well, this is a paper published in New England Journal of Medicine in 1994 by Oroplatt. And this is following a cohort of patients. This was an NIH-funded trial, followed over 3,000 patients with sickle cell disease over decades. And what she reported in New England Journal of Medicine in 1994 is that patients who had persistent fetal hemoglobin of over 8% have almost double the survival by age 50. So, which is quite impressive observation that patients with persistent fetal hemoglobin can potentially be protective and improves overall survival. So just as a reminder, the main hemoglobin during fetal development is fetal hemoglobin, which is shown here in red. And a few months after birth, the fetal hemoglobin starts disappearing and adult hemoglobin starts showing up. And in patients with sickle cell disease, this is when we start seeing the manifestations of the disease. And as I mentioned earlier, patients with beta thalassemia start experiencing severe anemia after they switch from fetal hemoglobin to adult hemoglobin because they cannot make enough hemoglobin A, or can't make any hemoglobin A, in fact, to sustain life. So something is happening here to preserve basically the propagation of the species. By every baby is born with, I tell patients, they are born with a hemoglobin of over 13 or 14 after birth, but very shortly afterwards, the switch happens between fetal hemoglobin and adult hemoglobin, and that's when the manifestation of sickle cell disease and beta thalassemia start. So there is a subset of patients that I know a lot of the audience might be familiar with that have persistent elevation in fetal hemoglobin, sometimes ranging in 20 to 30% range. And those patients seem to have less symptoms of their sickle cell disease and less transfusion dependence in beta thalassemia. So this picture here shows that if you achieve a hemoglobin F of around 20%, you definitely can have a milder disease state. And in patients who have around 30% fetal hemoglobin, they can be totally asymptomatic. So persistence of fetal hemoglobin can actually be protective for both patients with sickle cell disease as well as beta thalassemia. So nobody knew why patients switch from fetal hemoglobin to adult hemoglobin until studies were published around 15 years ago looking at genome-wide analysis, and they found that a gene called BCL11A mutations in that gene can make patients have persistent fetal hemoglobin. So lo and behold, scientists took animals and knocked down BCL11A, and when you knock down that or interrupt that gene, then animals will start producing high levels of gamma globin and thus high levels of fetal hemoglobin in the blood. So the discovery of BCL11A around 15 years ago was very interesting and intriguing, although we did not have ways to definitively interrupt that gene or change it in a human cell. Well, here comes CRISPR-Cas9 gene editing tool, which actually changed the landscape of human genome treatment. So CRISPR-Cas9 consists of Cas9 enzyme and a single guide RNA. The single guide RNA will guide the CRISPR-Cas9 and a single guide RNA form a complex and function as a unit to edit target DNA. And basically, the guide RNA will bind into the target genome and then make a disruption. During the repair of the edited DNA, a change in the target DNA is introduced. And in this situation, what we are going to talk about today is making a DNA break at the BCL11A locus. So what we are attempting to use is, our goal is to edit the specific region of the BCL11A gene to decrease the expression of BCL11A protein and increase the expression of gamma globin, and thus allowing patients to make high amount of fetal hemoglobin. And that could potentially be protective for patients with sickle cell disease and curative for patients with beta thalassemia. So in normal healthy volunteers, what has been done is you mobilize peripheral blood stem cells, and when you use CRISPR-Cas9 with a guide RNA specifically targeting the erythroid enhancer of the BCL11A gene, you can see that you can actually achieve high levels of gene editing in this 6-patient cohort. There was around 80% of the stem cells were able to be gene edited. And when we look at the data after engrafting those patients into animal model, you can see that the preclinical data shows that those edited cells can produce high levels of fetal hemoglobin, basically in the 30 to 40% range, as compared to the control group that has not been edited. So what is gene editing approach here that we are using is, we'll talk about it a little bit more details here in a minute. Patients, when they participate in these clinical trials, they undergo apheresis. Then the stem cells are basically electroporated, use something called electroporation. So to get CRISPR-Cas9 inside the cell, you have to electrocute the cells, basically. You subject them to a small electric current, and then you get actually pores in the membrane, allowing the CRISPR-Cas9 and guide RNA to go inside the cell, and causes disruption in the BCL11A gene enhancer in the erythroid enhancer region, and thus allowing the cells to produce high levels of fetal hemoglobin and protecting them from sickling, basically. So we know that naturally occurring genetic polymorphisms in the BCL11A gene are associated with elevated fetal hemoglobin. And we know that BCL11A suppresses expression of gamma globin. When animals were able to be treated with BCL11A reactivation gamma globin, when editing of the BCL11A gene in animal models resulted in gamma globin expression and very high levels of fetal hemoglobin in the mouse model. So what we attempted to do is replicate those animal data in humans. So there are 2 ongoing clinical trials. One is CLIMB 111 and one is CLIMB 121. And the 111 trial was accruing because it has met accrual. Patients between ages 12 and 35 years of age with transfusion-dependent beta thalassemia that require at least 10 units of blood per year or 100 mLs per kilogram per year. And the primary efficacy endpoint is the proportion of patients achieving and maintaining weighted average hemoglobin of greater than 9 without red cell transfusion for at least 12 consecutive months after exa-cel infusion. And we actually looked at engraftment, hemoglobin F levels in the blood, and the number of edited cells in the bone marrow and peripheral blood. Similarly, 121, trial 121 is finished enrolling patients 12 to 35 years of age who had severe sickle cell disease. Now, severe sickle cell disease was defined as 2 vaso-occlusive crises per year in the last 2 years. And the primary efficacy endpoint was the proportion of patients who have not experienced any severe vaso-occlusive disease for at least 12 consecutive months after the infusion of the cells. And we again looked at engraftment and percent editing in the blood. So this is how the schema goes. For patients are usually enrolled and they are screened. Peripheral blood stem cells are collected because sickle cell patients cannot use GCSF to collect peripheral blood from. We usually use plerixafor only for patients with sickle cell disease, and a combination of GCSF and plerixafor in beta thalassemia patients. Then the cells are edited, they come back to the center. The patients undergo a preparative chemotherapy with pharmacokinetically adjusted busulfan, and then myeloablative doses, just to mention, 4 days of busulfan, and the cells are infused and the patients are then monitored. So the CLIMB 111 enrolled, I'm going to present data here on the first 44 patients that have been infused. The median age of those patients, there were 21 male, 23 female, and the median age was 21, ranging from 21 to mid-30s. And 31% of the patient had beta-0 genotype, which is severe genotype, and an additional 27% had a beta-0 like. So more than half the patients in this trial had severe genotype, and the others had non-beta-0. And the historic number of red blood cell transfusions is here, which is, as expected, is very high for this population. For the sickle cell population, we enrolled 16 male and 15 male. We are going to talk about 31 patients treated with this approach. Majority of the patient had beta-S, and the number of vaso-occlusive crises per year was 3.9, ranging from 2 to 9. And the cells infused, the thalassemia group received a slightly higher cell dose of 7.5 million CD34 per kilogram. The sickle cell patients received 4 million. Neutrophil engraftment was comparable at 29, 27 days respectively for the Thal and sickle cell patient. And platelet engraftment was at day 43 and day 32. And the median follow-up here is around a year for the 2 study cohort patients. So to start with, I'm going to talk about the beta thalassemia group, which include 44 patients with transfusion-dependent beta thalassemia. And as Salim mentioned earlier in his talk, 42 out of the 44 patients treated are transfusion independent. This is a little bit of a busy slide, but as you can see, the light gray here is when the patients were receiving a blood transfusion, and the majority of the patients, basically over 90% of the patients, are transfusion independent. And the 2 patients who had not yet stopped transfusions had a 75 and 89% decrease in the transfusion requirement as compared to the pre-infusion of the XSL. Similarly, in patients with sickle cell disease, they remain to be vaso-occlusive crisis-free. So these are 31 patients who have received XSL. And as you can see on the left-hand side here, the number of hospitalizations or ER visits per year in the last 2 years. And none of the patients experienced any sickle cell-related complications after infusion of the XSL, with a median follow-up of 2 months to almost 3 years. So when we looked at the beta thalassemia cohort, this dark blue line here is the fetal hemoglobin. The light here is A, and the other color is A2. And as you can see, but when you look at patients by around 6 months, more than around 9 grams of the hemoglobin, 9 out of the 11 grams of hemoglobin are made of fetal hemoglobin. So fetal hemoglobin is almost more than 90% of the entire hemoglobin in the blood. And that has resulted in sustained increase in fetal hemoglobin as well as in the total hemoglobin. As you can see, this is a patient that was the first patient treated on this trial, now is sitting at a hemoglobin of 14.3, which you don't expect in a patient in beta thalassemia. Similarly, patients with sickle cell disease, by around 6 months post-infusion of the cells, this dark blue line represents the fetal hemoglobin amount, and more than 40% of the hemoglobin is made of fetal hemoglobin, which persisted over time. In addition, the patients pre-transplant had a hemoglobin in the 7 to 8 range, and now they are almost normal hemoglobin in the blood. And of note, there was significant reduction in hemolysis markers in all patients treated with sickle cell disease. So all patients maintained this fetal hemoglobin and it remained very stable over time. We also wanted to look at fetal hemoglobin in the red blood cells. So we did flow cytometry in the blood of patients over time. And the flow cytometry can detect the red blood cells that have fetal hemoglobin in them. And by around 6 months post-infusion of the XSL, more than 95% of the red blood cells contain fetal hemoglobin, which is very important point here. That means the fetal hemoglobin distribution is pancellular, which is quite different than when you give, for example, hydroxyurea to patients with sickle cell disease, because some patients will have high red blood cell content, some have none. Here we have a relatively uniform distribution of our fetal hemoglobin. We also evaluated the presence of edited cells in the blood and bone marrow. This is bone marrow data. So we performed bone marrows at 6 months, 12 months, and 2 years post-infusion of XSL. And as you can see, the CD34s, so this is primarily CD34. This is sorted cells. We look at CD34 cells. And as you can see in the Thal population, as well as in the sickle cell population, there is a very stable engraftment of the gene-edited cells that were infused. Similarly, in the blood, we have seen a rise and then continued engraftment of our gene-edited cells, resulting in high gene editing rate in the mononuclear cells. So the safety profile, as you expect for those of you who do transplant, know that using high-dose busulfan that is myeloablative can result in many complications, including fever, neutropenia, mucositis, alopecia. So these are complications that have been reported with this trial, the majority of which are related to what you expect to see with patients undergoing myeloablative transplant. There were no deaths and no secondary malignancies reported in this cohort of patients. So 1 patient with DTT and 3 patients with transfusion-dependent thalassemia had 3 serious adverse events related to XSL. 1 patient developed hemophagocytosis, HLH, which has been described after autologous transplant, and that patient was treated and the HLH resolved and the patient is doing well. And 1 patient with TDT had a SAE related to both XSL and busulfan with delayed neutrophil engraftment and platelet engraftment, but eventually engrafted. And no patients in the sickle cell disease had any serious adverse event related to the gene-edited cells that were infused. So in conclusion, we have data on 31 patients with sickle cell disease showing that single-dose infusion of XSL increase the hemoglobin F and total hemoglobin, and results in patients having no vaso-occlusive crisis following the infusion of cells. And similarly, what we found that XSL infusion can result in transfusion independence in the majority of patients with beta thalassemia. And we actually, the idea that CRISPR-Cas9 was discovered 10 years ago and was placed in the first patient a little bit over 3 years ago, basically 7 years after discovery, is pretty astonishing. So both patients with sickle cell disease and beta thalassemia are basically functionally cured from their diseases. So what are the advantages and disadvantages of this approach? The big advantage is you don't need a donor, so everybody can actually undergo this trial. I know some speakers commented on the side effects in patients who are older, and what we have shown here that in patients up to age 35, that this is safe and doable. There is no risk of graft rejection or graft versus host disease. And more importantly, some limitations that continue to be determined is, are these approaches really curative? We don't know because we need to follow patients longer. The follow-up is really short. And as John mentioned earlier, the need of high-dose chemotherapy is limiting because of the risk of infertility and secondary malignancy. Thankfully, in the gene editing trial, we have not seen any secondary malignancy, but autologous transplant in general is associated with a potential risk of secondary malignancy. This is very difficult to do in resource-poor countries. This is very hard to transfer to Africa and do it to all patients. And it is too early to evaluate if this approach will alter the organ damage. We are following patients and we are going to follow them for 15 years. And I think we just have to wait and see if this approach will affect the long-term organ dysfunction in both patients with beta thalassemia as well as sickle cell disease. I would like to finish by thanking the patients that participated on this trial. This is Victoria Gray, which got a lot of national attention in the US as the first patient with sickle cell that received the CRISPR-Cas9 gene editing. She basically signed up without having any data on any patient. We told her we don't know if this is going to work. She said, sign me up, and she has been doing extremely well. I'm happy to take any questions.